Hello, this is Dr. Manish Kothari from Jasloka Hospital, Mumbai and Alpha Spine Malad. I'm showing a cervical disc case of left-sided C6, C7 acute soft disc herniation causing neurological deficit. These are the MRI views. The surgery was done through an endoscope, 5 mm working channel. Uh, Once you dock your sleeve at the facet and lamina junction, you encounter the muscle. You have to ablate the muscle as much as you can, delineate the bony anatomy. I'm using my RF probe, and this is the upper lamina, which is C6 in this case, on the left side. Uh, this is the flavum that I can palpate. I'm ablating the tissue at the junction of the bone and the flavum to try to create a plane. What you would do in an open surgery using the curette, you can do the same thing using your RF probe. Clear the tissue as much as you can so that your bone and flavum anatomy is clear. Then you start drilling the upper lamina. I use a cutting burr initially, and as you cut, and you need to continuously make a plane. The RF probe is the best instrument to do that. You can use a curette, angle curette as well, but I don't like to use that in cervical spine because you need to enter the canal and the space is quite limited in the cervical spine. So you keep burring till you see a clear lamina, the bone and the flavum junction. You take small kerosene bites. I like to take bit by bit. I don't like to burr the entire bone in one go. I like to burr a bit, see what is the extent of my anatomy, and then burr again as required. I have now reached the lower lamina, which is C7 in this case. This lower lamina will dip into the canal, so you'll have to go much deeper than your upper lamina. You need to have a clear orientation of your anatomy to be able to do that. Once the flavum is detached, you need to detach the flavum on the lateral part which goes into the canal. Uh, you can use either a grasper or a kerosene, whatever works in your hand. You only need to remove the flavum so as to you can be able to see the nerve root. You don't need to remove the central flavum. That's optional, up to you. In this case, I've used a curved upward grasper to remove the flavum. There's some bleeding which I've cauterized using my RF probe. As you can see, I have switched to the diamond burr now because the cord is open. You need to also keep palpating and be aware of your bony anatomy all the time. I've switched back to the cutting burr in this case because the diamond burr was not doing a good job. Um, Once you start seeing the root, you need to decompress the root a bit more laterally. Do not go more than 50% of the facet joint. You can check that on C-arm or you can palpate using your RF probe. Once you've seen the disc, which is caudal to the nerve root, you need to kind of gently probe the disc material. The main chunk or the big fragment of the disc will be quite visible, and you can pick them up using a grasper. You can also put a thin sleeve in the axilla of the disc, but I don't like to do that in the cervical spine. There will never be one single fragment. Generally, there are more than 2 or 3 fragments. In this case, I had 5 fragments. You don't always get to pick them up in an endoscopy. They would just get washed away in the saline. Remember, this is cervical spine, so your fragments are quite tiny. The space overall is quite tight. I'm using my nerve hook. The pressure is always on the bone, on the disc, so that there is no pressure on the cord. Once you've make sure that all your fragments are free, the root is free, you use a dissector to probe the disc, and any free material can be removed. Unlike a lumbar disc where you can enter the inside the disc, in cervical spine generally that is not needed. You just need to probe and make sure the free fragments are out. In this case, there's a osteophyte which is not compressive, so I'm not going to drill that. That's the centimeter, which is a centimeter incision. That's the amount of disc that you can remove. Thank you. Thank you for watching.